I'm Natalie Pageler, Chief Medical Information Officer at Stanford Children's Health, as well as a board-certified pediatric intensivist and clinical informaticist. I'm also the Fellowship Director for Stanford Medicine, where I get to work with a very bright, energetic group of fellows who are working to improve the EHR and healthcare in general. We work across Stanford Medicine, and Lance Downing, who you saw earlier as one of our graduates. I think you can see that this field is really helping us to create a group of experts who will continue to make these areas better. I am very excited to introduce this last session. We've got a remarkable group of innovators who are working to improve patient, family, and provider experience and access to data. So with that, I'll introduce our first speaker. Josh Mandel is the Chief Architect at Microsoft Healthcare. He's also Chief Architect of Smart Health IT, as well as an instructor at the Harvard Department of Biomedical Informatics. He is leading the data standards community to improve access to data for improved analytics, frictionless data access, and app integration. So with that, please welcome Josh.
So I want to talk with you for a few minutes about consumer data access, and just start off by saying that over the last decade, we've seen a few iterations, a few kind of policy attempts at improving consumer data access. And we'll dig in a little bit to the technology as well as the policy side here. But the sort of first wave that came around 2010, 2012 was just a federal policy initiative to push for consumer portal data access, give people a way to sign into a portal and view their data online. The next wave, sort of 2014, 2015 came, which was really focused on downloading documents. How do I sign into my portal and save a file, which might be an overall clinical summary or an encounter summary from a particular hospitalization or event, and keep it somewhere. And the wave that we're in now is really focused on API access. So how can I take an app of my own choice and connect it to my health records in some meaningful, ongoing fashion? And so we've seen these waves of effort from the policy perspective. And I want to say that right now we're at kind of a historic, and at least for me, a pretty interesting time for two reasons. So one is that the rules which came into effect in 2015 that first sort of laid out these API access requirements, well, at the time, the Office of the National Coordinator for Health IT focused on a particular data set. It was called a common clinical data set, things like medications and problems and labs and allergies and immunizations. And they didn't lock down a particular standard, but what they did was to create what's called a functional requirement that says every certified health record system needs to have some kind of API. And you got to make the documentation public so that app developers can come and read it. But they didn't lock in the requirements for any particular standard, just had to be public. But major vendors came together. This was an effort from the Argonaut project, and agreed outside of the rulemaking process, just the vendors together agreed to do this using a consistent FHIR-based approach, using these kinds of smart on FHIR APIs. And these things have gone into production over the last few years. But right now, in October of 2019, it's an interesting time because of the way the incentive program is put together. This is the last window of time that provider organizations have in order to have a 90-day reporting period before the end of this year. And so starting at the beginning of this month, that's the last available 90-day reporting window for organizations to actually demonstrate that they've turned these APIs on. So there's been a big push among providers to get these APIs on and available. So that's reason number one, that this is a particularly interesting time. And the second reason is that there's, again, been a major regulatory push starting earlier this year with a set of proposed rules from the ONC and from CMS to expand the sets of data that are available through these APIs and to make it easier for app developers to connect to API endpoints, to register their applications, and to request access. And this is important for a couple of reasons. We have these proposed rules right now that would expand the data sets not just to include some of the structured data that we've been talking about, the meds and problems and allergies, but also to include clinical notes and narrative text, which, as we know from working with almost any particular question you might want to ask, this is where the thought process goes. This is where clinicians get to write down the assessment that they made and the rationale for their choices. So if you're running a research study and you have some narrow question to answer, chances are that you're going to find the answer to that question locked up in a document somewhere. So this is the first time we're really starting to see a push to make these notes available through a consistent standard API. I do want to mention, just given the first session from this morning's talks, we're still talking about a fixed set of data categories, sort of what's called the US core data for interoperability. And that lists out these discrete data categories and clinical notes and basically says, these are the kinds of things that an app needs to be able to get through an API. It's still not everything in the health record. It's basically a bottom-up effort to enumerate all the things that must be included, rather than a top-down effort to say, all patient data need to be available. And so that's an important limitation to the API efforts in ONC's proposed rules. But at the same time, next to those API requirements, there's something called EHI, Electronic Health Information Export. And that's really the top-down effort, where ONC said, in addition to all the discrete data and the APIs, you've got to have some way to kick off an export job, to allow a patient to basically save a file that's got data in it that represents all of their health information. And this is an area that doesn't necessarily need to be standardized, but is much more complete. And so these are two complementary approaches that go very well hand in hand. The bottom-up standards effort and the top-down approach to say, you know what, even if you don't have a way to standardize it, at least make it available to consumers through some consistent method. And we are seeing a vigorous national debate right now around these proposed rules. They were proposed back in February, tens of thousands of discrete comments from thousands of organizations that were shared back with ONC and CMS, some of which were positive, saying, yes, we like this direction, some of which really urged a lot of caution. And we've seen a pretty strong pushback, a lot from provider-centric organizations, so organizations like the American Medical Association, around consumer API access. And many of these concerns are focused around privacy and security of data, raising issues like how can consumers know which apps are trustworthy? And how do we know that app developers are going to rise to providing the level of protections that consumers need and that they deserve? We've even seen this kind of pushback from some of the informatics organizations. So AMIA, the American Medical Informatics Association, signed on to a letter to Congress a few weeks ago, sort of echoing some of these concerns. Now, from my perspective, I think that we've actually got a great foundation to build out this kind of consumer access. I want to highlight sort of three key areas or challenges that I see and what I look at as the low-hanging fruit. I actually think that we're in a good position to move ahead with this kind of push for consumer data access. And even though there are still some challenges that we need to address, I don't see any showstoppers. I want to see if I can convince you on this front. So one of the key challenges has been how does an app developer communicate their privacy policies and terms of service? And let's step out of the healthcare world for a moment and just think about the broader consumer web, social applications, tools that you use in your everyday consumer life. Typically, these apps have very complicated terms of services and privacy policies, and they're all available. You can click through a link and read them, scrolling through tens of pages if you so choose. But usually what happens is that people just click through an agreement without ever reading those things, and certainly without understanding them. And that is really kind of the state of the art when it comes to your consumer experience outside of healthcare. Every day, people probably give away more access to their data and agree to terms of sharing that are broader than they really understand. And they do it because they're getting something convenient out on the other side, and they just sort of push aside the worry or the concern, and they just keep going. We have some reasons to think that healthcare data are more privileged, although I would submit to folks in this room, even though healthcare data absolutely deserve a privileged degree of protection, most of our consumer data are also extremely sensitive. And so, for example, if you think about a complete history of every web search that you ever did, everything you ever typed into a search engine, and you think about somebody making that public with your name next to it, how does that compare with taking your health records and making that public with your name next to it? How do you assess the relative sort of risks? I don't have a complete answer on this one, but I will share a little story about the kinds of things that I choose to make public. So what's the low-hanging fruit here? How can we do better in the healthcare space? Well, there have been a few efforts to provide the kind of model privacy notice or consistent set of questions that we can ask health app developers to explain their privacy policies, to boil them down to a few key figures, similar to the way you might do with a nutrition label on a product. The nutrition label doesn't tell you everything about how that product was created, doesn't tell you every molecule that's in the food, but it gives you a list of ingredients, and it gives you a list of high-level macronutrient contents. And there have been efforts to do similar things in the healthcare space, things like ONC's Model Privacy Notice, things like the Karen Alliance's rules of conduct, as well as individual vendor-led efforts. Like Epic has a questionnaire that developers are asked to fill out when they create a consumer app, which has a number of detailed and thoughtful questions about how the app developer is going to make use of data, and how those data might be shared with or without explicit opt-in from a consumer. So I think the low-hanging fruit here is to allow developers to opt into those kinds of frameworks and to display that kind of information for consumers at the point when they're going to make a decision to share their data with an app. And if a developer doesn't want to opt in, if they don't want to boil down their privacy policy to something simple, I don't think that's grounds to prevent that developer from building an app, but maybe there's a scary warning. Maybe you present a consumer with a red flag that says, look, this app developer was unwilling to express their privacy policy in readable terms. Proceed at your own risk if you want to proceed. So for me, that's sort of the low-hanging fruit when it comes to explaining these privacy policies. Hold on. I need to pause and do a time check. Do I have less than 1 minute left? Somebody give me the time view? What was the answer on this? 30 seconds. OK, so that was one of 3 key topic areas that I wanted to describe. The other 2, just for your records, are data permission granularity. So how do I make decisions about what parts of my record I share? Do I have to share my whole record, or can I dial in narrow amounts? And here, I think the low-hanging fruit is to start with the coarse-grained things that we understand pretty well, and just let consumers share their data with apps that they actually trust, because that's the thing that we know how to implement well today. And the third area was managing identity across many providers. Today, we've got these networks where consumers might have records that are fragmented across lots of provider systems. And the state of the art is basically this probabilistic identity matching, where providers might be able to look up data based on your name and address and a probable match. We think it's likely that these 2 records correspond to the same person. This is a very hard problem to work out at scale, but the low-hanging fruit is building on some of the portal accounts that we already have today, where you've got a relationship with one provider, you've got an account you can use to sign in there, and we should leverage those existing portal accounts anywhere we can. Final thought, I've been actually super encouraged to see where we are today. I was able, for the first time this year, to connect to my own healthcare data through these kinds of APIs. I was able to download my data using the Smart on Fire API from 2 healthcare providers in my home state of Wisconsin. And the thing that I did with those data was to publish them openly on my GitHub account so that developers could come in and see what real-world health data looks like, both where they conform to the standards and where there's some surprises and gaps. For me, that was a reasonable thing to do given my clinical history, but I'd like to make it easy for any consumer to opt in to the level of sharing that they feel comfortable with, which might be no sharing at all, might be making data publicly available, or might be most likely somewhere in the middle. So I'll stop there. Thank you.
So with that, I'd like to introduce our next speaker, Stephen Lin. Stephen is the medical director of Stanford Family Medicine and vice chair for technology innovation in the Division of Primary Care and Population Health here at Stanford. He has been leading some tremendous work over the past several years to introduce AI and auto-scribing. So he's going to talk with us about the present and future of team documentation.
So thank you, everyone. It's really great to be here. My name's Steve, and I'm here to talk to you today about team documentation and what I think will be a critical role for patients, families, and artificial intelligence. So I'm a family physician, and for those of you who are clinicians out there, I imagine you have, at some point, felt the toxic effects of burnout. Physician burnout has now reached epidemic levels in the US, with the latest data showing that about 44% of us have experienced at least one major symptom of burnout in the last 12 months. We know that burnout is associated with a lot of bad things: major medical errors, poor patient outcomes, higher cost of care, attrition, substance abuse, even suicide amongst providers. So what's causing all of this? What's behind this? Well, the reasons are pretty complicated, but one thing is for sure. Study after study shows that a key contributor is the burden of clinical documentation in the electronic health record. And in fact, things have gotten so bad that now for every 1 hour providers are spending in front of patients, they're spending 2 more hours in front of the EHR, largely on clinical documentation. Some of that documentation is important and necessary, bolsters ongoing patient care. But a lot of it is wasted. And that wasted time can account for up to $90 to $140 billion a year in lost physician productivity. So all this has led to the rise of an entire industry of medical scribes and the concept of team documentation. The scribes have been around in the emergency room since the 1970s, more broadly in other medical specialties in the last 20 years. But in the last 10 years, they've really exploded. And we now have a body of evidence supporting its use in the medical setting. So, for example, we know that scribes decrease provider documentation time, they improve their job satisfaction, and they do not detract from patient satisfaction. We also know that scribes increase provider face time with patients and the level of engagement with patients, that they do improve work-life balance and burnout symptoms, increases the quality of documentation in otherwise error-prone charts, and improves productivity and revenue. Industry projections estimate that by next year, there will be 1 scribe for every 9 physicians in the US, with demand far outpacing supply. So now's a good time for us to review all of the different team documentation models out there and its key strengths and weaknesses. So I think of scribes as coming in 4 flavors: commercial, staff, learner, and digital. The commercial scribes are probably what you think about when you talk about scribes. So these are third-party vendors who have recruited, trained, managed, and then contracting scribes out to individual providers, practices, and health systems. Companies like Scribe America, for example, use this model, and it's pretty plug and play. So the advantage for health systems is that it's low effort to implement. The disadvantage, though, is that startup and maintenance costs can be high. And in some lower earning specialties, like primary care, which also happens to be the most burnt out, it's difficult sometimes to make the economic justification for them. A variation of this model is the remote scribe. So you can see here that the provider is wearing technology like Google Glass, for example, that's beaming the information from the examination room to an offsite location where human scribes documenting the encounter. Companies like Augmetics, for example, use this model, and it shares many of the same traits and characteristics as before. A second category is the staff scribe. And so some systems have decided they don't want to contract out, and they want to build this capacity internally. And so they train medical assistants or nurses or use advanced practice providers like PAs or NPs to share the documentation burden. The great advantage of this is that it's team-based care with all of the benefits of teamwork that's been shown in the literature. The disadvantage, though, is that it requires a higher staff-to-provider ratio. And again, for some specialties, that's something that's difficult to muster financially. And some people believe that it's really just pushing the burden of burnout onto another healthcare team member without really creating additional capacity for documentation support. The third category is the learner scribe, so using medical students or pre-medical students who are enrolled in tuition-paying academic programs in which scribing is a component of their service learning. That's very cost-effective, and the experience itself actually benefits the learners. The downside, though, is that there is a natural rhythm of turnover for these learners, and the scalability and generalizability of the model remains unclear outside of the academic setting. And lastly, we come to the digital scribe, leveraging the power of artificial intelligence. With advances in automatic speech recognition and natural language processing, we now have the ability to create algorithms and devices that can listen in on physician-provider conversations and actually document certain aspects of the note. So theoretically, this would be highly scalable and cost-effective. But as with any emerging technology, safety, accuracy, reliability needs to be established first. But it's actually very exciting stuff. And in the last couple of years alone, more than a dozen companies, big and small, have actually ventured into this space. At Stanford, my team and I have been working with Google over the last 2.5 years on this problem. And we've learned a lot of very interesting things along the way. The first thing we learned is that it's actually a very difficult computer science problem. Patient histories are often nonlinear, circuitous, multi-layered, sometimes even internally contradictory. And to teach an algorithm how to recognize what's important, what's not, where to put what data, and then to clean up some of those internal inconsistencies, that's a non-trivial pursuit. As I've said to many engineers who've come to me, it's simply not good enough to do a direct voice-to-text transcription. And in fact, that would probably make a pretty terrible note. The second thing we learned is that for it to reach its full potential, the digital scribe cannot be limited to the data verbalized within the four walls of the examination room. I'll tell you what I mean. So maybe I'm seeing a patient that's being discharged from the hospital. I need to know exactly what happened during that hospitalization so I can put that data into my notes and my treatment plan. It's very unlikely, though, that all of the data I need will be verbalized during that patient visit. So I actually need to go and get that data from the EHR ahead of time. Or my human scribe will do that. And so I hope my digital scribe could do the same. Or maybe I'm seeing a medically complicated patient who has multiple specialists within the healthcare system. I need to know exactly what happened at those offices so I can incorporate that into my notes and treatment plan. And again, highly unlikely that everything I need will be verbalized. So ideally, my digital scribe would get that data for me. And let's not forget the single greatest source of information out there, which is from the patient's home. As a PCP, most of my encounters with patients now are actually through text messages, through the patient health portal, or telephone encounters, or video visits. These virtual touches now outnumber my traditional clinic visits 2-to-1. So if a digital scribe is restricted to the data that's verbalized within the four walls of the examination room, then its utility would be limited compared to a good human scribe. But if it could actually get out there, access all this data, synthesize it for the provider into a cohesive patient narrative at the point of care, that would be a game changer. And lastly, I just want to talk about patients and families a little bit, because I don't think we talk about them enough in conversations like this. So traditionally, CMS guidelines has not allowed patients to be actively engaged in the generation of their own notes, and I think that's a mistake. I think if we want to get to a future with fewer burnt-out doctors, better notes, higher quality, less error-prone, more patient-centered, and notes that the patients can actually engage with in their own health, we need to change those rules. Fortunately, guidelines are relaxing a bit, and in the last year alone, CMS has allowed learners and other members of the healthcare team to help providers document. So why not patients and families? After all, what are notes except stories about patients? And shouldn't patients have the right to be co-authors in their own stories? I think that with technology like smartphones and smart speakers, now in the hands of more and more Americans, we finally have an opportunity to make that a reality at scale, using the most accessible and natural form of communication available to humans, our voices. And so I leave you with a vision for the future of clinical documentation, where providers, patients and families, and all members of the healthcare team come together and collaborate as co-equal storytellers in the generation of the patient narrative, using the power of our voices and voice-enabled AI scribes. Thank you.
And finally, I have the pleasure to introduce Amy Merlino and Allison Weathers, both from Cleveland Clinic. Amy is the enterprise CMIO and an obstetrician and gynecologist, and Allison is the associate CMIO and a neurologist. And we've been talking a lot today about some of the pain points in the EHR, and they are going to talk to us about their program to get rid of some of the stupid stuff.
Thanks for having us here today to talk about this, and it's been great through the day to hear a lot of the points that we were trying to address have sort of come up through the day. So we've been on an electronic health record at the Cleveland Clinic for almost 2 decades now, and being an early adopter and starting this journey as medical care has been changing, as regulations have been coming on, all the things that we've been hearing about. At the Cleveland Clinic, we've also had some significant growth of our organization over that time, so bringing in new members of our Cleveland Clinic family and how that's layered on top of our electronic health record over the years has really provided us with a big opportunity within our IT department. And we're constantly trying to figure out how we can partner with our colleagues that we work with to really figure out how to make the tools work for them. So this is a great cartoon that I think many of us have seen. What is the customer saying? How do we get to the project, and what do we really end up with? So despite our great informatics teams that we have working with our customers providing us input, we don't always get where we want to be. And then the barnacles that have been collecting in the health record over time really have collected to get to a point where we need to figure out what it is we can do to really help our providers. And so as our informatics team's constantly thinking about how can we help our caregivers, this article came out and it really kind of piqued our interest. So Dr. Ashton in Hawaii started this initiative that was really pretty simple, yet pretty innovative and straightforward. Ask the caregivers that are using the tools what it is that they find stupid in their daily work, and really think about how you can address that and get rid of it. And it's really simple, but it's that voice of the caregiver and being able to impact that that's important. One of the other key parts of this that they brought up that I think is also important is that many of these things that we call stupid now or see as these additions, that one more thing, they really were a good idea at some point or were based on something. So you want to respect that, but still have that opportunity to really listen to what folks need, make changes where you can, or at least validate what they've said that you've heard it and explain why we are where we are. So if you notice the timing on that was an article in November. I forgot our best slide here. Sorry. Allison did our slides, and I forgot the cute one. So as Picasso says, many will copy, but great artists will steal, and we did do that to steal shamelessly.
I like how we were described as remarkable innovators. We're
not. We stole things.
We're just really good thieves.
So around that same time in November, we had a turnover of our medical staff officers. And one of the first things that these 4 gentlemen did was to reach out with a questionnaire out to our physicians. And they were looking at different tools and resources and asking our physicians, what is it that we need to help? And as you can imagine, the electronic health record came in as part of this. So that provided us with some ammunition in addition to this great idea that we stole to try and really impact and help our caregivers. So as part of this, we also didn't want to get stuck into big bureaucracy of our large organization. We really wanted to figure out how to do this grassroots and get it done. And so Allison and I worked with our IT communications team to come up with a quick little survey tool that would allow us to do this, provided that concept of personal communication. We worked with the Office of Professional Staff Affairs through the Chief of Staff's office so that we could have support for this initiative from them when things came up that we needed their help with. We actually reached out to our nursing colleagues, and at this time they weren't as interested in participating in this, so we really targeted our physician caregivers in this work. And we got this launched in February, had it set up both off our website and also as a quick tool within Epic, putting it at that point of care when that stupid thing is happening. They can identify where that's at. And we kicked off on this journey, and now I'm going to pass it over to Allison to share what it was that we found and what we've done.
Thanks, Amy. So we started, as Amy said, in February, and since then we have had an incredibly robust response, as somewhat expected. So 675 submissions since then by a wide variety of people from a number of different departments, different roles. We do have a number of repeat submitters. So I think our top one has submitted 28 times, which... More power to her. And so we've broken down the data in a number of different ways, and you'll see some common themes as I go through it, but just wanted to kind of frame it in a couple of different ways. So when we think about the breakdown by team, so who do we, in some ways, farm these out to? Who's kind of responsible for owning what we find? This slide isn't exactly fair. It's a little misleading because our ambulatory makes up more than a quarter, but we separate on our inpatient ones into different groups. So when you add up all of our inpatient CDS, clinical decision support, our orders, our documentation, they work out to about equal. Now, Amy just made the point that nursing actually said this isn't kind of the right fit for us right this time, but people found the tool. So even though it wasn't marketed to them, the nursing staff found this and used it. And so nursing, and same with our kind of front end, registration, schedulers, same thing. This was posted on kind of the provider-facing websites. It was a button kind of in the provider, more geared in the provider views in Epic, but people found it and ended up with almost 10% kind of going to those teams. And 4% for the chart correction, and that was because, to take us a quick second, just as we've done traditionally at the Cleveland Clinic, we've, over the years, in some ways, hijacked some of the functionality for other roles. So that great little question mark icon of ask for help had actually been utilized by our chart correction team. So now we were sharing that button. So a number of people kind of clicked in and didn't take the time to see that the menu had changed. So we got a number of those as well. So I know it's a little bit cheesy, but I decided it's a kind of actually a nice way to see it is through the word cloud. So what were our recurring themes? And they were kind of what was expected. Clinical decision support, especially interruptive alerting. PAMA, Protecting Access to Medicare Act. There's been a lot of really great, thoughtful conversation around regulatory burden today. This was a big one. The timing of this rolled out very soon after people had started to see changes. We've been implementing gradually PAMA changes, and those were a big concern. We also timed this. We started it about a month or so right before an upgrade, and it was one of our biggest ones. There was a profound change in the way ambulatory orders were placed in our EHR. So that was a recurring theme. Again, with that chart correction and front end, but a number of other things, medication reconciliation, some functionality called phases of care around timing of orders, problem-oriented charting, and allowable number of charts. Somebody else mentioned that earlier today, and that had been a number change too. We reduced that, so we saw that as a theme as well. So I want to spend a few minutes going through, so it's nice to see the breakdown, but we thought some of these examples would really resonate with the group. And so we'll kind of walk through some of our I thought these were really very kind of clean cut about how this kind of split out. So the good, this one was brilliant. It was one of our first ones we got. And it was like, really, you waited to tell us this? Why? And it was for one particular site, one particular lab, but we didn't know. And so somebody had been living with this, a large number of providers, for quite a long time. So this was one we were able to get fixed very quickly, understandably so. So this was a great example. That was really pretty stupid. All right. So the bad, and this is bad, it was a really great point, and this really resonated with us. And we actually were able to go right back to Epic, and actually Sam, who I think is still in the audience, we had a great conversation. And unfortunately, there's some regulatory EHR certification limitations to getting this fixed because of the way it has to be designed to make it work across all vendors for right now. So this was, we considered it bad because yes, we agreed, this isn't ideal, but we can't really change it right now at this point. And then a little bit of a trigger warning before I show the ugly. Whatever you are imagining in your mind, it's going to be worse. It is, but I think so. This will be offensive. It was offensive to us, but we thought it was really important to show. So everybody's been warned. So the ugly, and I'll give people a second to read it. It was bad, and it's almost like when you see people like internet comments trolls, but this had their name on it. I'm going, really? But I think it really speaks to how, I warned everybody, how bad, how low people's resiliency has gotten, right? How, at what point are our providers that they felt compelled to do this? And so I think it was really a wake-up call that if somebody is feeling this strongly that this was how they had to respond, and in this forum, we have a problem. This entire room, why we're here today is because we know we have this problem. The other thing that I wanted to highlight about this one is that it really spoke to the importance of getting that partnership with our Office of Professional Staff Affairs and our chairs ahead of time. Even though we were able to do it quickly, we had that. So when we saw this, we could immediately reach out. And within an hour, there was a very formal apology letter. And we were able to kind of use it as a teaching moment. So I think having that partnership let us be able to respond to this in an appropriate way. So now, how do we fix it? What are our categories of solutions in my last few seconds? The exciting thing was a lot of it was education. Almost a third was stuff that was actually there. It was possible. It was something that was easy to do. We just aren't doing a great job of telling people about how to do it. So that was really eye-opening. We knew we'd get some of that, but it was nice to see how much of it there was, where the answer was already there. Again, that chart correction in front end, you've heard me say it a few times, but knowing that that's obviously a pain point, and we think and talk a lot about providers, but everybody is feeling it, and there's opportunities there. And then the others were divided pretty equally. Those break fixes and quick wins, what we call commentary, just people sharing their thoughts, which we appreciate, and it's important too to give people a venue for that. Optimizations, help desk, my printer's broken, this WOW isn't working, we got those too. Regulatory and system limitations and some of the others, and things that aligned with bigger efforts we were already working on. So very quickly, how did we make it work? The nice thing about this is we did not have to add any new meetings to do, did not have to add many new meetings. We added one. And actually, by this point, we normally actually end up canceling it several times, but it was just with our key group, Amy and I, our ITD administration and communications, just a touch point. And we were so fortunate that internal ITD communications is who collates these submissions. They're wonderful about being really proactive if they see leadership or something that's really concerning. They reach out. Otherwise, the work itself is integrated into our existing meetings and our sprints of our teams. It's prioritized against other requests. And we are the ones who review, investigate, and follow up with the requester and our OPSA, that Professional Staff Affairs Office, if needed. And we are fortunate to have provider specialists at the elbow support, and we use them heavily for that education piece. So our lessons learned, be prepared for the influx. We're thrilled we did it, but we are in some ways victims of our own successful marketing campaign, which is what we wanted, but we did not, if you'll notice, in that how we did it, it was not carve out time in Amy and Allison's schedule to devote to gross. So we are fitting this in between patients, between meetings, in the evenings, wherever we can. So it's added to our pajama time, but it's worth it. Have a well thought out way. We were grassroots, we wanted to get it off the ground very quickly. But if we would have probably been better at the beginning to have a more thoughtful way to implement this or integrate it into our existing processes. So now we tried to kind of make it fit because we don't want our teams to we don't want to add to their gross, their get stupid stuff. So how do we fit this into their existing ticket process and where they go for their work? And then to echo the point Amy made at the very beginning, no matter how good intentions are, I think about this a lot now as I make decisions. Is this going to be somebody's gross submission in 2 to 3 years or even 2 to 3 months? So trying to be thoughtful about how we think through things now. And I don't know if Sam has seen this, but I love this. I use it for everything. So this was a movie that came out about a decade ago, but the tagline just makes me happy. So thank you all very much.
Thank you all. Like I said, I really do. Whether or not it's completely innovative or not, it is pushing the boundaries on how we fix some of the problems we're talking about today. So thank you all for sharing your work. I've got a few questions to ask of the group, and then please think of your questions out there, and we'll have opportunities for the audience to ask questions as well. Josh, we'll start with you since you were running a bit short on time. I think you got to talk about your first issue quite a bit and how we think about third-party app privacy. But you started to talk about segmentation of data in that second topic, and can you expound a little bit on that?
Sure. So one of the challenges when it comes to consumers sharing their data is, how do you describe which data you want to share and which data you might prefer to hold back? Today, what we have is a pretty coarse-grained way of letting consumers say, for example, I want to share data in my medications list, but I don't want to share data from my problem list, or I don't want to share my immunizations. It's sort of segmented based on data categories. But a more meaningful way to break these things down often comes along functional lines. Like, for example, maybe I want to share my whole record except redact information that would have to do with my HIV status. And this kind of thing is meaningful from a consumer's perspective, but can be very difficult to implement technically in a way that actually works. So for example, withholding HIV status might mean keeping back an actual HIV lab test and those lab results. But there might be associated lab results. Just the fact that you had certain tests done might leak information about the fact that you might have an HIV diagnosis. Similarly, certain medications, details and phrases from clinical notes. There's lots of ways that this information could leak. And so this idea of very fine-grained privacy controls is appealing, but it can also be very difficult to implement in a technically correct way. And the question then becomes, well, who bears the risk of getting that wrong? So it's something that provider organizations don't necessarily want to be on the hook for. Technology vendors are certainly reluctant to be on the hook for making guarantees that are difficult to do from a technical perspective. And so this winds up being one of the areas where we have a lot of deep discussions about what's possible. And I just hope that those discussions don't prevent us from doing what we know how to do, which is the kind of coarse-grained sharing, where you find an app that you trust, and you make a decision to share certain categories with that app.
Great, thanks. I think it's a really important topic. There are the reasons why an individual may want to make decisions, but then we're also bound by state laws, for example, that may say that teens, for example, are allowed to have certain data and their parents aren't. And so there are places in in order to get everybody involved, we have to do some segmentation, but I totally agree. We have to start somewhere. We might as well start with the areas that we can control and think about some of those more complex details later. So thank you for sharing. Stephen, how about we go to you? I mean, I've been watching your work for a long time, super excited about the things that you've been leading. You talked about the 3 different types of scribes and talked about some of the advantages and disadvantages. As you've gone forward with the AI work, have there been any things that you're worried about in losing in terms of the human scribes, or that the human scribes really have advantages over the AI?
Yeah, we've been thinking about that a lot, actually. And the great thing about being at Stanford is that we actually have all of the different models that we presented here. And so in our division for our primary care, for example, we have a medical assistant model, and we also have the commercial scribe model in some of our other departments. And then we also have the learner scribe model, both medical students and pre-medical students. And so I think each of those models bring with it different strengths and weaknesses. And one thing that we found when we did studies on exactly what the impacts of these human scribes are, the thing that sort of spans all categories, which I think that an AI scribe would not be able to bring, would be sort of the fact that you have a partner in crime with you. And so unless you really work in very collaborative team-based care models that are fully matured, practice is very lonely. And so when we actually surveyed our physicians, one of the things that we saw over and over again was the scribes have a protective effect on burnout, but it's not just about documentation burden. And you'll see comments from the providers that it is such a joy to work with someone that follows me around all day. We can chat about clinical cases. I'm contributing to their education, and I just feel so much happier. And it's not as lonely as it used to be. And so I wonder if we're going to be missing that human element when we move to something like an AI model. But of course, I think the documentation burden is so big of a problem that we also need to think about ways that are very scalable, like AI solutions.
Interesting, fascinating insights. And I think that human connectedness is incredibly important. And as I was listening to you at your project as well, it really does seem like part of it is that human connectedness and feeling like somebody does care, somebody wants to hear what you're saying. So fascinating points. I want to give everybody in the audience a few minutes to ask questions if there are any out there.
Great job.
I think we've got a microphone coming to you. Perfect.
Great job on just all the issues and peripheral issues, and thank you for this. I have a question for Josh in terms of FHIR and the core data set. So what it seems like to me is that we have everything for like a mainstream 25-year-old to get their allergies and all of that. But in terms of these chronic comorbid patients that Dr. Singh was talking about earlier, when do you really see that core data set really maturing? And when do you really see FHIR or some other probable standard help? And the reason why I'm asking is because in terms of interoperability, like you can have document interoperability, but that doesn't really help a lot of physicians when they can't get things when they're on the go, for example. So if you really want API-based, mobility and interoperability, we really have to, as you know, really advance on some of these, core data elements. So can you tell us what can we do, all of us in this room, and what's the timeline on that? I know that's probably a few questions, but.
So maybe where I would start is just to say this concept of interoperability is really a lot of overlapping concerns that can lead to sort of different levels of being able to make use of information and plug into workflows of different kinds of participants in this ecosystem. So when it comes to modeling discrete data in the sort of core data set, I think we're in a reasonable position. And that's maybe a dozen of the resources that the FHIR standard defines. And typically what happens is a community will come together around those resources and agree about exactly how to use them. What clinical vocabularies, which properties are going to be consistently populated, which data elements in those resources. But the FHIR specification has on the order of 150 resources that can be used to capture lots of granular, structured data about care. Now, the truth is that populating those things in the real world is still quite hard. and that falling back on documents and narratives is still pretty valuable. I think there's a whole layer of what I might call middle-tier software that's going to be incredibly important. And for folks in this room to think about, if you've got access to a pile of discrete lab results and allergies and meds and a pile of narrative notes, you could think about building something that's incredibly useful for a mobile clinician that's based on search, right? Being able to quickly look for everything related to a particular diagnosis, that's smart enough to know synonyms and context and has enough natural language understanding to be able to find anything from a set of historical lab results to key phrases and sentiment analysis on the history of clinical narrative. And that set of stuff together, even though we don't have tremendous consistency on the clinical documentation, can still be quite powerful. Last thing I'll mention in just 10 seconds is that often these are not interoperability standards challenges. These are clinical care standards challenges. So the same patients might be worked up and treated and documented very differently in different organizations. And trying to rectify that all out on the data output side can be unrealistic.
Hi. So my question is, we all as caregivers, we go through all of our training, and a lot of what we learn is the vocabulary to speak to one another. And things like what labs and results might be outside of a clinical range but are not clinically relevant, and what is clinically relevant and what isn't. And when we now talk about sharing all of that data with the patients, so sharing our notes, sharing their lab results, which they absolutely have a right and the legal right to access, there's a lot of back translation that then needs to happen. And I was wondering if anyone sees a role for AI in that sort of back translation, because I think some of the resistance in caregivers to releasing all of that is the extra time spent then having to go over that with patients. So I was wondering if that's a thought.
Yes. Yes, there is. Yeah.
I think there's a clear role there. Maybe one quick principle would be, when it comes to sharing these data with consumers, to think about separating, here's the data, so here were the notes that were documented as part of your care, separating that layer from the interpretation layer. Like, here's a tool that can help you make sense of it, so that people can bring their own preferred sort of interpretation tools, whether it's a friend or colleague, or whether it's an artificial intelligence tool to help them make sense of what they've got.
And we've had some experience with just releasing information to patients in a standard way, not all of this. And that was one of the big concerns. If we let people see their labs, are they going to call us with everything? If we let them see their notes, are they going to be writing back and telling us to correct them, and there's increased burden? And I don't think we saw that impact of the patients really doing that and reaching back into the medical system as much. A few, but not quite as much as our clinicians were really worried about.
And I think that experience has been echoed across the country by many other sites. Howard Levy from Hopkins has a great quote about this being a non-issue. We all had those concerns, and it just hasn't come to light. So I think that's reassuring. But I agree, it would be an amazing use of AI, because maybe they're wondering and they're driving elsewhere because they don't want to bother their clinician. So I think there's a ton of potential there.
And I think sometimes it's not the AI actually translating the clinical jargon to medical speak, but sometimes the technology itself can actually affect physician behavior. So when we were doing our collaboration here, one thing we noticed is that when the clinicians were being recorded for this project, they were communicating in ways that were deeper, richer, and using language that was more patient-centered and less jargony than when they weren't being recorded.
That's fascinating.
And so if you ask them, why did you notice that this was happening? Why are you doing this? Some people will say, well, I just want to make sure that all of this information is captured in a way that's accessible to the patients, because all of our notes are available on open notes. Yeah. And so this is one way to really engage the patients in their own care. And then some people didn't even realize that they were doing this, because it's just the Hawthorne effect of being observed, right? Or there's something happening there. And so I think that's a wonderful example of how technologies can actually sometimes influence positive human behavior from providers.
All right.
I was just going to say, it gets back to us being humans again.
Exactly, absolutely. Great final thought. We are out of time for this session, but we will have lunch in a moment where people can find you all and ask more questions, so be prepared. With that, I'd like to invite Dean Miner back to the stage for some final comments. Thank you all.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.